Assalamualaikum doctors. In this video I am discussing the management of SIADH syndrome, inappropriate antidiuretic hormone. First of all, what is SIADH? It is a condition in which the body makes too much antidiuretic hormone ADH. ADH is also called vasopressin. This hormone helps the kidney control the amount of water your body loses through the urine. SIADH causes your body to retain too much water. That's why puffy eye is the features. Pathophysiology of SIADH is that the hormone increases the water reabsorption in the distal nephron, producing concentrated urine and diluted plasma. Vasopressin release is stimulated by any of the following: increase plasma osmolarity, decrease the blood volume. Causes of SIADH: number 1, medicines such as certain seizures medicines, antidepressants, cancer medicines, opiates less often, and heart, diabetes, and blood pressure medicines. Number 2, surgery under general anesthesia. Number 3, disorders of the brain such as injury, infections, and stroke. Rare diseases of the hypothalamus or pituitary. Number 4, brain surgery is the region of the hypothalamus. And number 5, tuberculosis, cancer, chronic infections, and lung disease such as pneumonia, leukemia, and cancer of the small intestine, pancreas. So remember the causes of SIADH, very important, because it can become on the history, the sequence. There is pneumonia with SIADH come. So leukemia, cancer, chronic infection, tuberculosis can be after brain surgery, any brain injury. These are can be developed. Pneumonia with SIADH develop, and the puffiness, abnormal movement develop. So how is SIADH diagnosis? Lab investigations. Lab investigation, we do the serum sodium, potassium chloride, and bicarbonate, plasma osmolarity, serum creatinine, blood urea nitrogen, blood glucose, urine osmolarity, serum uric acid, serum cortisol, toxicology screening. Full septic workup, full blood count, ESR, CRP, sputum culture, blood culture, radiology, chest X-ray, CT chest, brain, CT or MRI. So electrolytes level we are doing: creatinine, blood urea nitrogen, blood glucose, urine osmolarity, serum uric acid, serum cortisol, toxicology screening, and full septic work we are doing. Diagnostic criteria of SIADH are: common diagnostic criteria for SIADH: decreased serum osmolarity less than 275 milliosmol per kg, euvolumia, urine osmolarity more than 100 milliosmol per kg, urine sodium excretion more than 40 millimole per liter, normal renal functions, hyponatremia, sodium is less than 135 millimole per liter. Then criteria indicating like not SIADH, that is urine osmolarity less than 100 millimole per kg, increase or decrease volume status, hyperglycemia, polydipsia, polyuria, and severe hyperlipidemia. What is the treatment of SIADH? First of all, correcting the hyponatremia too rapidly may result in central pontine myelinolysis (CPM) with permanent neurologic deficits. The goal is to correct the hyponatremia at a rate that does not cause neurologic complications as follows: raise serum sodium by 0.5 to 1 milliequivalent per hour and not more than 10 to 12 milliequivalent in the first 24 hours. Aim at maximum serum sodium of 125 to 130 milliequivalent per liter. Fluid and water restriction is the first line treatment of SIADH. So first line, fluid and water restriction. Then hypertonic saline. It is an effective medication for management of symptomatic hyponatremia regardless of the underlying etiology and can be used to increase the serum sodium. Second line treatments include increasing solute intake with 0.25 to 0.50 gram per kg per day of a urea or a combination of low dose loop diuretics and oral sodium chloride. Urea is known to promote the diuresis. It decreases the brain edema, restores the medullary tonicity, and induces sodium retention. If the condition is chronic, fluid restriction may need to be permanent. Treatment may also include certain medications that inhibit the action of ADH, vasopressin, surgical removal of a tumor that is producing ADH, other medicines to help the regulate body fluid volume such as the demiclocycline or lithium, which decrease the effect of vasopressin on the kidneys, or medications such as conivaptan or tolvaptan, which block vasopressin receptors. So these are the treatment of SIADH, that is correction of the sodium, hyponatremia. Very slowly we will do. Number 1. Number 2, fluid and water restriction, hypertonic saline we give. Then second line treatment we give a combination of a low dose diuretics and oral sodium chloride. These are the treatment. And what is the prognosis of patient with SIADH? Depends on the underlying cause and the effects of the severe hyponatremia and potential overcorrections. Prompt and complete recovery is generally the case with drug-induced SIADH once the offending agent is withdrawn. management of pneumonia. So our case is pneumonia with SIADH. So pneumonia management is assess the child condition, ABC, vitals, oxygen saturation. If severe distress, SpO2 less than 92% in air. So admission, prescribe oxygen, gentle suction to clear the nasal secretions, analgesic, antibiotic, IV fluids, and start antibiotics. Antibiotic for pneumonia are uncomplicated oral amoxicillin, vomiting IV benzoyl penicillin, severe IV amoxiclav plus oral macrolide, influenza amoxiclav plus oseltamivir, Staphylococcus aureus is coamoxiclav or flucoxacillin, aspiration is amoxiclav, and hospital required tazocin. So mainly we are giving oral amoxicillin, and if severe condition IV amoxiclav or oral macrolide we are giving, and hospital required tazocin. Duration of the treatment is improving in 24 to 48 hours, then change IV to oral. Physiotherapy once cough is productive. Maintain hydration by oral or IV if oral not tolerated on 80% maintenance. If not improving 24 to 48 hours, repeat the X-ray plus review treatment. Uncomplicated total course of 7 days, and complicated with Staphylococcus aureus total course is 14 days. Community acquired total course is 14 to 21 days. Discharge and follow-up. First of all, follow-up X-ray if round pneumonia or collapse or persistence of the symptoms. Hospital follow-up, previous respiratory tract infections and failure to thrive. And GP follow-up 6 to 8 weeks, other cause. So mainly we understand ABC, oxygen saturations, we think clear the nasal secretions, everything. We are giving an antibiotic, we are giving mild, moderate, severe. Mild we are giving oral amoxicillin, severe IV amoxiclav and oral macrolide. And when improve the child 24 to 48 hours, we will be shift to the oral. And the treatment is uncomplicated 7 days, complicated 14 days, 7 to 14 days, and if it is community acquired then 14 to 21 days. Then follow up with the X-ray if there is consolidations, pneumonia, round pneumonia present then. Hospital follow up, previous and respiratory tract infection, failure to thrive, and GP follow up 6 to 8 weeks, other cases. So this is all about pneumonia with SIADH history management. Thank you.